Ladies and gentlemen, I'd like to invite to the stage now Professor Chan. God knows what interesting physical things that may occur in the next hour. Could I also welcome Dr David Kissane and Jenni Bourke? If you could all take a seat. Two of the ones with microphones would be good. Could you make them welcome? And the focus of this session is holistic care, rehabilitation and family dynamics. And I guess we're aiming to explore what actually makes up holistic integrated palliative care and what makes it possible to look at the role of rehabilitation in palliative care and to look at this issue of family dynamics and the impact of family dynamics. I wonder if I can start with Jenni Bourke, and let me introduce Jenni. Well, I should introduce you all first. Jenni is a senior occupational therapist at the Peter MacCallum Cancer Centre with specialist qualifications from Melbourne University in palliative care. And you'll see that people's CVs in your program. Jenni has the most amazingly diverse background of experience. Would you please make Jenni welcome? Professor Chan, I won't invite again, but I'd like you this time to clap her by thumping a part of your body or pounding it. Thank you. And I'd also like to welcome Dr David Cassane, who's the head of psychiatry at Monash, a palliative care physician, a psycho-oncology researcher. And I'll just mention a couple of things from his CV. He's been involved in a cognitive existential model of group therapy for women with early-stage breast cancer, as well as working with women with advanced breast cancer. He has a model of family therapy and family care and work on demoralisation as a variation on depression and meaning-based coping. I basically read that out because it just sounded so interesting. Would you please make him welcome? Let me start with you, Jenni, if I may. First of all, before I ask you about what these words holistic care means to you, what was going through your mind as you watched Professor Chan? How do we make East meet West?
Oh, I was delighted. I was freezing cold, so it was brilliant for me. I got really warmed up. But it reminded me of a question that comes up a lot in practice. It comes up a lot in these conversations, thank you, which is about cultural awareness. And it's a funny term, and I'm not sure that I understand it. But when I was listening to you and engaging in those activities, what it made me more aware of is if I was in Hong Kong and someone came in and did this with me, how would I respond to that? And would I think that was kind of normal or okay or acceptable to me? So on the flip side of that, if I go into someone's room and that's what's acceptable and valued and important for them, and I completely disregard that, I'm inadvertently alienating people. I might be doing the best job I can do, but I might be inadvertently alienating people because I don't know what I don't know. So I thank you for educating me this morning. It was fantastic.
Yes, thank you. Could you just give, if you've got a microphone, Professor Chan, I think that's a really excellent point Jenni makes, because you took us into another world and another philosophy, another way of thinking, and it made me realise just the poverty of my cultural understanding. And in a society like Australia, where we have people from so many backgrounds, what would be your advice to us in terms of how on earth we could be culturally sensitive in reality when we're dealing with people from such diverse backgrounds? This is something you would face in Hong Kong as well.
Oh, in fact, Hong Kong is also adopting NHS system because we were a British colony before, and
put the microphone close to your mouth.
And we don't adopt a lot of these Chinese methods, nor focus on well-being. We focus on symptoms and treatment as well. I went to China to visit one of the OH daycare facilities, and they learned the daycare facilities from Hong Kong with the high back chairs and the elderly people. But meanwhile, I saw the elderly people were doing acupressure on themselves with the neighborhood doctor coming and said 1, 2, 3, 4, 5, 6, 7, pressing on themselves on the acupuncture points and doing these simple exercises while they were sitting down. So I thought in our daycare, we were doing this poorly for the physiotherapy. One single thing for 45 minutes is a bit boring. But if they were doing this integrative hand movement, chi energy pulling and acupressure, their health improved and they were much happier without their knowing it. Because by simply doing those traditional exercises, they improve, their mood, their general well-being improve. So I thought I should learn from China, what they have been doing, and brought it back into Hong Kong. And actually, most of these techniques I learned from my patients, from my cancer patients, because I asked them, what works for you? And they have tried out all sorts of complementary alternative methods. So they share with me what works, and I further simplified them so that it can be taught to anyone, even elderly people who are illiterate, young children, because I think it's so important that we simplify things enough so that anybody can master this. So it's a people-to-people spread of information and knowledge and exercises and have fun without being a therapist and a receiver, service recipient, that hierarchy. So everybody is the same.
Thank you. Could you give the microphone to Dr Cassane? David, how did you respond as you were listening? Before I move on to the next session, I'm trying to, this is about integration, so let's integrate our two sessions.
Thanks, Julie. Psychiatry has the biopsychosocial spiritual model, and I could see the great similarity between that particular philosophy and what Cece was proposing as an integrative Eastern approach. I thought of a student who's studying mindfulness and of how many of those techniques would be applicable activities in a mindfulness model. And the hypothesis that this doctoral student's working on is that mindfulness decreases mind wandering. And when people worry, of course, the rumination of worry is a mind wandering, returning again and again in a habitual way to that sore point. And so I think these exercises are terrific approaches to stop mind wandering and really focus the attention to other aspects. And that's the skill that people develop as they pursue these activities. Cognitive therapy does things like thought blocking and distraction therapy, not as elegant as some of these, not as saleable to people. Have an elastic band around your wrist, twang it, cause pain if that annoying thought is coming back in an obsessional way. Some of these techniques are terrific to stop the mind wandering, and I thought they were very impressive.
Thank you very much. Well, so let me come to you, Jenny, and come to this issue of holistic care. How would you explain what it means? Do you want to have a go at a definition?
Oh my goodness. I have a slightly different definition, and I think it's interesting that the three people sitting up here all have a slightly different but probably overlapping definition. And I think my experience of working within palliative care is it is that psychosocial, spiritual and physical, but where I practice, what I see is that there's a big component of the physical that we forget, and that is about physical function. So a lot of us here would work in teams that are fantastic at managing symptoms. We do really good symptom control. We're able to try and keep people at home longer. They're more comfortable. And then what do we do with that? Why are we doing this? What are we trying to engage someone in? I mean, pain control is really important, because what you need to do then is use that pain-free time to do something of enormous value, enormous personal value. And what I've heard people talk about a lot over yesterday and even just now is about seeing the person, being engaged, choosing things that are really important to the person, not to us as a team, but to that person. So I think there's an element of holistic care here that's underexplored and underreported in the literature, and it's something that I see in my patients getting potentially a bit neglected. So I agree with all of the things that have been said, and I would like to add that as a challenge of the way that we think about it.
Tell us a bit more then about the role of rehabilitation as part of palliative care, because that's one of the themes of this session.
It is, and I think it's for some people it's a really controversial, mind-bending kind of concept, because in traditional rehabilitation what we aim to do is achieve function, and we aim to recover function, and we aim to achieve some sort of stable function. So it seems to work in direct contrast in some people's minds to what happens in palliative care. And I think it's important to be a bit of a pedant here and say that palliative care, to my mind, purely just means non-curative. It doesn't mean nearly dead. And I think there's a real confusion between palliative care, actively living up until the point you die, versus terminal care, which is that real end of life phase. So when people that don't work in this cohort or area hear palliative, I still get this experience of people throwing up their hands and going, oh, but they're dying anyway, why would I bother? And I think, oh, that's really challenging. And I think so the concept of rehabilitation with palliative care is utterly mind-blowing. And yet for those of us that work in the field, we know that our patients do every bit as well as the patients that have had a stroke, as the patients that have chronic respiratory diseases, patients that have cardiac problems, and they're all traditional rehabilitation cohort patients. So what's wrong with our guys? Nothing. Their level of motivation is incredibly high, they have good outcomes, they're really motivated, they're engaged, they're living. Living's almost more vitally important to them. So why would we deny them that opportunity? But the idea of putting rehab and palliative care in the same sentence still, I think, is more of a problem for clinicians and practitioners than patients.
I feel like this is an incredibly important point, if I may say, as an outsider, because I don't think people do associate rehabilitation with palliative care. And I mean, it can be the difference between being able to go to the bathroom until the day you die. Who doesn't want to be able to go to the toilet themselves until the day they die? I consider that a life goal, to be perfectly blunt.
You're absolutely right, and research would say that that is exactly what people want to be able to do. It's as simple as that.
And so that rehab until the last moment is what it's about. Listen, could I just ask Pauline Serda? Where's Pauline? Because you're Pauline? Do you want to just come over here, Pauline? Because Pauline, until very recently, was a rehabilitation clinician in palliative care, and you're just crazy for rehabilitation, aren't you, in palliative care? So tell us about your passion for occupational therapy and physiotherapy.
I'm crazy anyway, but for physiotherapy and occupational therapy, because as Jenni said, people have goals, people want to achieve something. And when I was working, people would come into the ward and want to achieve something, but because it's not acceptable as much, it's much harder to get the more in-depth rehabilitation going. And it's just little things like sitting up and a wife crying and saying, this is the best hug I've had for years, because he hadn't been able to do more than lie down.
When you say it's hard to get it going, are we talking about resources, referral, the right to treat? Like what's the nitty-gritty of this?
I think it's all of the above, but I also think it's understanding that, putting it basically, they're not dead yet and they want to do something. And they want to achieve their goals that will make their life easier, make their family's life easier. We've had people in a palliative care unit that are still working. They want to be able to achieve that. And they need to keep their strength up, they need to be able to go to the toilet, they need to be able to do a lot of things, and that's where OT and physio come in.
We're going to have a panel this afternoon that's about advocacy beyond the palliative care community. But I'm just mindful, I think it was Bob Arnold who said change will be driven by the community and not by the profession. Because I guess I'm interested in how you think the change will happen so that rehabilitation referral for people in palliative care becomes a normal expectation within the health system.
I think if I knew the true answer to that, it would be done. But I think it's a very complex issue. I think
What are the main barriers?
understanding that it is part of life to achieve these goals. It's a money issue for the government, it's employing OTs and physios in these places, it's giving them more than 8 or 16 hours a week to do what is necessary, it's education to OTs and physios, it's education to staff, it's education out of that into rehab units to say, even though they've got cancer, they can still achieve something. You're treating a stroke patient, why won't you treat a palliative patient? It definitely is governmental, it's administration. So, Julie, it's the whole lot.
Thank you so much. Thank you. Would you give her a round of applause? Jenni, what's your sense of the key barriers to becoming normal, and your thoughts on how the change can happen?
Yeah, it's a good question. I think what I've become aware of and what surprised me the most is if you mention the word cancer, so the big C word, people back away. If you add that with the P word, palliative, they've run in the opposite direction. So I think...
Who are these people who are running? I mean, you're talking about professionals or...
Yeah, I am actually. I think one of the biggest barriers is us being able to access existing services. So for me, one of the huge barriers is an equity barrier. We're not assessing people based on their needs and their personal goals and their levels of motivation. We're kind of, there's still some societal preconceived ideas around diseases like cancer and for patients that fall into that palliative group. And I mean, it's kind of bizarre because, you know, I'm thinking about the advanced breast cancer group, for example. I've worked with women who've had metastatic disease for 12 years. There's a lot of life in these women, you know? So I think a lot of it's around shifting societal ideas around this stuff, because all of the clinicians and the people that enable access to rehab, or the doctors that make the referral, or the families that go, why are you doing this, need to make that shift in their own brains. So it's a bit like, who was talking about it yesterday? It was wonderful, about, was it Kerry? About the social networking, and that by people being involved, they learn to understand and then spread the word. And I think it's a very similar thing. I think if people experience it, understand it, spread the word, talk to their friend who talks to their friend who knows someone with cancer, whose mother's budgerigar, toenail clipper, you know, the whole thing. And it just, it spreads. But I think our role, because we know it's valuable, is to advocate very strongly for our patients. And that can be upwards at a government level, and it can be all the way down to working with families to say, you know, it's actually okay that your mum wants to stand and get the dishes out of the dishwasher, and you're terrified because you think she's a falls risk and this is a bad thing, and you want to wrap her in cotton wool and keep her safe. But this is how she engages with you as a family member. And someone mentioned about the meaningfulness of occupation, but it's also about reciprocity. If we're in a family or any relationship, well, if it's one way, you probably want to get out of it, but most of our relationships are two-way. We learn to receive and feel loved and valued, and we learn to give and provide love and provide value. So by giving people the opportunity for rehabilitation to remain engaged and active for as long as they can, we're actually adding value to their life, and I think it impacts on things like demoralisation, for example. It's vital. Being able to get from your bed to a chair, vital. Being able to wipe your own bottom, for some people, is more important than anything. And I think we slip into the habit of going, oh, but that's okay, I can do it for you. Well, we can, but that's not okay for everybody. Some people go, great, you wipe my bottom because I'd rather do that. Others would go, absolutely not, no way. It's really important and valuable to me. And that's that patient-centred, I believe. That's the essence of patient-centred care. What is their goal? How can we help them achieve that? How can we advocate for them at whatever level to make sure that happens?
So there's a clear link between the physical function and the mental health, but in the context of reciprocity and relationship, you enter the spiritual realm as well. Look, before I move on from this issue of rehabilitation and come to Dr Cassane, is there someone who'd like to comment or ask a question just relating particularly to this issue of rehabilitation and palliative care? Just if there's someone wishing to comment. Thank you.
Kat Swift, Warrigal Hospital. My concern is when I see these sorts of issues with palliative care patients in the hospital setting, and the OTs and the physios are generally very young people, lovely professional staff, but their anxiety about the person becoming injured or having a fall or, you know, making some terrible thing happen to themselves overrides any of this quality of life stuff. And I find that really frustrating. So as a senior occupational therapist, Jenny, what can I say to them?
What a fantastic question. It actually comes back to the fact that I think as a society we've become really risk averse. We take slides out of playgrounds. Kids don't know how to swing or climb trees anymore. I mean, seriously, we're really risk averse.
But also there has been major state and federal campaigns on falls prevention for good reason. People die in hospital from falls. So I can see why these young... You're caught between the right to autonomy and all the... You know, there's now... I'm in hospitals all the time because of my mum. And there's signs everywhere about falls prevention. So in a way, our campaigns might be having an unintended consequence.
Well, I think what we're talking about is finding the middle ground here, because, you know, as a society we've become risk averse. As young therapists, we're not as confident perhaps in taking some of those professional risks, and we don't know how to assess the level of risk that we're taking. And I think sometimes, and this is something I've talked to Pauline about, when you mature as a professional and you have that a much better understanding of things, it's easy to ask the right questions and get the right equipment or get more people in and go, all right, let's have a crack at this. So we're not saying, let's let people fall over randomly, let's take ridiculous risks. What we're wanting to take is a calculated risk, and that's based on clinical reasoning. What do we know about someone's physical strength? Are they on dexamethasone? Are they likely to have, you know, any kind of proximal weakness? We're not saying throw out the rule book and not be smart about this, but how can we use our smarts and match that with the patient goal? And I think the point that you're making here is about good supervision, good mentoring, being able to speak to other people, to learn how to assess those things and gain professional confidence for the benefit of our patients. And I think, you know, as a new grad, I would have been terrified as well. There are still times when I think, ooh, but, you know, that's what your colleagues are for, and that's why we work in teams and why OT traditionally work very close with physio. So we can take what we would consider a calculated, reasonable risk, not be reckless. There's a difference between being reckless.
Look, thank you very much. I'll come back to you, Jenny, on another matter, but David, I wondered if I could come to you. And first of all, what would be your definition of holistic care?
Integrated whole person and whole family care. I think the psychological perspective wants to remind people of distress being the sixth vital sign, beyond temperature, pulse, blood pressure, resps. Of course, here in this room, people think of pain as the fifth vital sign. And distress as the sixth vital sign is now adopted as a message by UICC, WHO, and it's a very important thing. So just to be Bob Arnold for a moment, I might say it's a bit of ask and ask and ask. How's your morale? How are you managing? What's life like? And it's being open to these questions, having an interest in the person, and then plenty of tell me more. Tell me more about your life. And this is how we understand the person and the family, and really ensure that our holistic care is person-centred and family-centred in that way.
Can you tell me how many palliative care patients would be in need of a formal referral to someone with qualifications such as yourself or a clinical psychologist? You know, because many people here are volunteers or nurses and maybe in contact with care workers. How does one just differentiate, I guess, between the natural ups and downs of having a life-limiting illness and needing more help than that?
Many good studies today have been very clear about this, with rates of clinical depression of the order of 10 to 20%, depending upon whether somebody's more early stage or advanced in their cancer journey. Depression increasing as people get closer to the end of their life. And recent systematic review of demoralisation has pointed to rates between 13 and 18% across a series of 25 studies. So up to 1 in 5 people should be needing some form of more developed psychological support than perhaps is there within the ordinary team.
And do we have those resources?
We've really got to build those resources. I think we've been improving, and palliative care's made some great strides at a state and at a federal level in setting standards and having a requirement for what proportion of an employment ratio should be allocated to people with psychiatry, social work, psychology on teams. But there's a lot more to do. There's a lot to grow that skill base. There just is a huge amount to develop. We can look at some very prominent services and see that they're well developed, but there are plenty of other services around more remote areas where that's not available.
And is there capacity building? We've had a lot of emphasis in our first day on palliative care consultants providing special support to staff, whether it be in aged care or other contexts. Is there similar capacity building happening in relation to mental health issues?
More is needed, more by way of supervision of people. When teams are struggling with difficult cases, how do they go about reaching out to colleagues that may have greater expertise and gain supervision to put together ideas to handle the complex, difficult cases, whether at an individual level or at a family level. Services, I think, have such available, but many psychiatry services would say that nobody asks them to come into the palliative care setting and consult and work with and assist in that way. So I'd encourage people to speak up, to make the links, to not wait until a parcel of dollars are made available, because it's very hard to get government to give more dollars out, more and more and more. But if people make the links and you draw clinicians in to work with your team, then I think you can achieve a lot.
And tell us a bit more about the difference between demoralisation and depression.
How's your morale? How's your mood? Morale, of course, is a simpler concept in many ways, where people can be buoyed and enthusiastic and getting a lot of fulfilment in what they do, but they can also easily become disheartened and drop their morale. And it's good, I think, to ask people about their morale, but differentiate that from how's your mood. Is there sadness? How are you managing with that? That's a simple idea of that benefit.
And I assume many people would be more open to talking about it, because depression, people might be resistant to thinking they're depressed, but morale is almost something we associate with wartime, don't we? How's your morale?
Yeah, it's a much better way to start.
It's a more open-ended way of asking the question. I obviously am full of questions, but can I offer an opportunity for any questions or comments about what we've talked about so far in relation to, thank you, to anything at all, in fact?
Hi, I'm Jenny. I'm a day hospice nurse at Western Health. And I'm just wondering, we have access at the day hospice, as we're hospital-based, to OT, physio, psychology, and I'm currently doing a research project to bring complementary therapies into palliative care. And we're also affiliated with Mercy Health in the community, so we have access to counsellors, music therapy, but our referrals are very low. And how do we... it's 10 years our service has been there, and I've always struggled to promote that we are there, that we exist. How do we bridge that gap to get and I know the need is out there, to get the patients in.
Just before I get your thoughts, what do you think is the problem? Because you're obviously trying.
I think from what Jenny was saying about the lack of understanding, even within our own, our own profession, it's education maybe, but that's what I struggle with. How do we get the patients there to access these wonderful services?
Thank you. Who'd like to comment on that?
I've got one reflection that clinicians, I think, often think of OT as a group of experts who'll come and do an assessment, tell us what's safe, what's manageable. And clinicians don't think enough about using the OT services to treat, to increase the range of function, to do more for the person. And I think if there was marketing about treatment approaches as well as assessment, that might shift the mindset of the clinician as one source of initiating the referral.
What do you think, Jenni?
I've had a little bit
the
of it.
reproduction's on the top.
Oh, sorry. God. That's why I don't do what you do. I think there's a couple of things, and in my long time ago past, I worked in a community centre, and day centres they were called then. It was a similar thing. And I think sometimes people don't understand what we do, and we rah about day hospice, this, that and the other, or our centre does this, that and the other, and sometimes you have to kind of flip it on their head. If we go back to the concept that people don't know what they don't know, you need to kind of say, what do I need them to know? Have you got patients that are experiencing this? Have you got families that need some respite, and who? Have you got people in the community that are isolated and crying out for some kind of connection and respite and connection with others? Or do they need opportunity to come to groups that create legacy, or whatever it is that you do? But I find that your internal networks are often a good place to start, so you can get referrals before people get scattered to the four corners. But presumably these people have got some kind of community-based nursing. So who are the people that are most likely to see this population that you can make networks with, connection with, and connect some of the dots and develop some kind of collaboration with? When I worked in community, it was a fairly geographically defined space, so you knew who all the other services were. So I used to physically go and meet people and have lunch, because there's only so much you can do by email. I get so tired of email. I'd much rather have a yarn. Just get out there, I reckon.
Thank you. I'll just come over here. So you have to build human relationships. Do you want to just start?
Hi, I'm Tanya from the Southern Metro Region Consortium, and a lot of people here will know what I'm going to say. One of the reasons why there are less referrals to all sorts of different practitioners, especially in the Western region, is because there's a very high number of people who don't speak English very well. We know from the Victorian Palliative Care Satisfaction Survey that still, out of these people who answered the survey, half of them said that they didn't get an interpreter when they needed one. So how do you find out what their needs are? I don't know. And then you make assumptions that, oh yeah, the family is going to care for them, rather than, you know, trying to talk with them through an interpreter and referring them to day hospice, referring them to physiotherapy, occupational therapy. So access issues still there.
Thank you very much. And I think I saw a hand here. Do you want to just come down so people can stare at you? No. Do you want to just, would you stand just for that level of, like, hi. Do you want to introduce yourself?
My name's Lana, and I've just finished a lifestyle qualification. So, you know, if there's any other lifestyle people out there, that'll be lovely to say hello. Maybe my interest is in doing creativity in, and also look at rehabilitation goals in lifestyle. That's my particular interest. And I'm wondering, just as a comment, is that perhaps there needs to be a new term. If rehabilitation in palliative care is just too overwhelming, both for the client, the family and staff, perhaps there needs to be a new term like re-engagement, or something that is going to be a little bit more palatable.
Just tell us what lifestyle is. What do you mean you've been doing a lifestyle qualification? What does that mean?
It's Cert 4 in leisure and health, and doing activities with people in aged care, community.
Thank you. Sorry, I'm an outsider, so I just didn't know what it meant. Thank you. Would you like to comment on that? Or another issue? I just wondered, would anyone like to comment on that? That if the word rehabilitation in palliative care is confronting, is a new use of language a tool? I'll come in 1 second. Is there anyone on... Is this on that point? Well, I'll come to you first. So just, do you mind?
Oh, no, sorry. Look, I've been to a few sessions on survivorship, and I see that there are so many parallels between survivorship and palliative care.
So survivorship, do you want to explain what that means?
Survivorship traditionally is people who survive cancer and then go on to live their lives. Sometimes with metastatic disease, some survivors will say that they've beaten the initial and they're then going on to live. Some people with curative who consider they've been cured. But when I was listening to the aims of supporting survivors, I really felt that there are synergies with palliative care, and especially because some survivors consider that they have survived their initial onset and they're still alive, despite the fact that they're probably their death is more imminent. And I just think sometimes maybe we could sell stuff, things like rehab, quality of life, if we started to have that mindset that these are survivors, as long as they are alive, they are surviving their terminal illness. So I just wonder if we can reframe. Maybe we can help the survivorship cause as well as ourselves in palliative care to think more in terms of that concept.
And linking it specifically to the theme here of holistic care, in the survivorship work, there is talk about physical, mental and spiritual. It's also an integrated thing. So again, in a sense, two comments going to the question of language. It's almost as if rehabilitation is for people with a future, and people think if you've got palliative care, you don't have a future. I think it's as clumsy as that, isn't it?
And so we're fighting stigma. That stigma develops about what's my future, what are my abilities. Is it stigmatised to go to a day centre? Lifestyle, survivorship, rehab, all of these words help to reframe a concept that may be unwelcome to an individual who hasn't yet come to accept where they're at, how their life's unfolding, what their future is. And I think if we're creative, we select these terms and shift them around so we're finding words that are not going to be a barrier to the person that you're wanting to move to a new acceptance and go forward with their life as well as they're able to do.
I guess the one thing I challenge in what you've said is I wonder if the attitudes of your fellow health professionals are a more significant barrier to these referrals and engagement than the attitude of the individual and their family. I think if you don't mind me commenting as an outsider, I MC all sorts of conferences, and mostly all of health meet alone. The OTs meet alone, the nurses meet alone. The nurses let the midwives in, but you can feel the tension. That's only partly a joke. You know, when you get to the doctors, the GPs meet alone. I'll go on. No one meets with the psychiatrist. My God, you're considered too weird. You know, I'll come to you. I've noted you're present. So, what's refreshing about palliative care, as an example, is you all mix together. You do think in teams. I think my observation, this is just as an outsider, is that cancer has also made the jump to integrated conferences. They even, for goodness sake, fill up the room with people who've had cancer. So it's the culture. It's not just that health is hierarchical. It's savagely divided. And they just think you're ramps and rails. You know that. I'm being a bit rude there, but occupational therapy, most people, they don't think access to life, access to relationships. I'm trying to be a bit provocative, but...
Good on you.
Well, but in a sense this is urgent, because if you're the family member or the patient themselves, you really don't know what you don't know, and if you guys won't respect and talk to each other, we can be stuffed.
And I absolutely agree with that. And I think we have to be brave enough to be controversial. We have to say things that are provoking. And, you know, there's a lot of fantastic stuff about palliative care, and we could sit here all day and tell all the great stories. But I think we learn and we develop and we grow by telling the stories that aren't so great and saying, we've nailed this, we do this really, really well. Where do we want to shift this to now? What do we want to add to that? What are we not doing so well? Or what are we ready to take on next? Or what have we forgotten?
And what we're hearing today is use language to market yourself better to each other, and you may get more contact with patients. That's part of what I'm hearing. I've got two people I'm going to come to, and just to let you know, we're heading towards a discussion of family dynamics and its impact on the capacity to deliver holistic care. But let's take our two audience members first. Do you want to introduce yourself?
Yeah, hi, I'm Annette. I'm from West Hume, and I presented about carers and the needs of carers yesterday. And I'm just hearing these things about language and maybe we need to rename things and all that kind of stuff. We need to get back to grassroots. We need to call it for what it is. I just heard before that there were 2 or 3 people that were doing things that nobody even knew what they were. We need to get back to simple, easy language and call it for what it is so that our patients and their carers and their families understand us. We start adding in other words about, you know, I don't know, well-being and, you know, whatever we were talking about. This is about let's get you back on your feet. Let's get you moving again. So that's my take-home message.
Keep it simple.
Everybody turn around and look in this direction because this lady's up here. Come up the front so a few people can at least see you. Yeah.
Oh, yeah, I forgot the rules, sorry.
Do you want to introduce yourself?
Yeah, I'm Molly from Austin Health. I guess for me the big thing is around wellness, and those of you who know me will know that we have a cancer and wellness centre at Austin Health, and the reason that wellness is embedded in the name is because the focus is very much on how do we get people, no matter where they are in their illness trajectory, where they are in their life adventure, in a state of maximum wellness or maximum well-being. And I know wellness is a bit of a buzzword, however, I guess I'm no different from any of you, that I want to be as well as I can be, and I think for our patients and families, they are entitled to expect exactly the same. So that means instead of always focusing on deficit, we need to be focusing on capacity and saying to people, okay, what are the important things for you to be able to achieve, and how can we help facilitate that for you? So the whole idea around wellness being that it's integrated with the other treatment pathways. So when we wrap all that together, people need to have a wellness prescription, I guess, that goes along with their chemotherapy treatment or their radiotherapy or whatever it is, their medication.
And give us an example of it. Do you mind coming down the front just so people can see you? Because everyone's going to get a crick in their neck and then Professor Chan will pound them. I just wonder if you give us an example of a wellness prescription.
Okay, so that's about getting the person to identify firstly what the important things are for them. So if an important thing is about being able to move around physically, how do we build up their muscular strength within capacity to enable them to move around as independently as possible? And when they aren't able to move around independently, how do we facilitate them still being engaged in what's going on, even if they have a physical deficit? So again, focusing on people's capacity, not their deficits. So a wellness prescription might include things like diet, exercise. It might include therapies like massage therapy. It might include expressive therapies like art therapy, music therapy, or it might include things like just being able to get down to the CWA where you've been a member for 20 years and continue to go to those meetings. That may give you your sense of health and well-being, and that's what we need to be facilitating.
You know, this session's about holistic, and is embedded in what you've just said, a concern for mental health and spiritual well-being?
Absolutely.
So how would you distinguish between mental health and spiritual health? What's the difference?
I don't think you need to. Really, at the end of the day, if someone's worried about what's going to happen to them after they die, that's their fear. They don't brand it as being existential distress. They say, I'm scared about what's going to happen to me after I die, or I'm scared about what's going to happen to my family. So that's the way we need to be addressing it. And I think if we, and this is just my view, and you know, those of you who know me know I'd like to stir the pot. I think if we navel gaze too much about this stuff, we lose the essence of what we're here to do. So we need to be handing it back to the patient and saying, you know, you tell me what's important to you, and I'll do the best I can do to facilitate that as a member of a team.
And how do people get referred to your wellness centre? Because part of what we're talking about today is getting professionals to refer people to integrated teams.
to be honest, we don't have any trouble getting referrals, and in fact it's the opposite. So, you know, our service is relatively new. It's only been up and running for just over 2 years, and we have ongoing pressure really around the breadth and scope of what we can offer. But patients, any of the patients at the Austin can have massage therapy, they can have acupuncture, we're running mindfulness training very soon, we have yoga, you know, we have groups, and hopefully over time we'll be extending that, you know, and music and art therapy, hopefully over time we'll be extending that to the more adventurous complementary therapies that people access out in the community but that we've been a bit slow to embrace.
Like what?
Like reflexology and Reiki and those sorts of things that that people are generally accessing themselves when they're not in the hospital.
Right, thank you so much. Thank you. Would you give Molly a round of applause? What my intention is to do, and I'll obviously give you another opportunity to raise your own issues, I'll just come to you in one moment if I may, sir, is to talk about family dynamics and also suffering, because it's something that Professor Chan mentioned. I might come to suffering first so I don't miss it. Can you grab a microphone? In your presentation, you talked a lot about meaning reconstruction and integrating reminiscence and celebration. So these were different words about this end-of-life period. And there were a number of mentions in your slides about the meaning of suffering and the place of suffering. Could you talk a little bit about where you see suffering in this issue of holistic care at end of life?
There is a tendency for us to avoid suffering and pain, but in fact, facing death itself is a suffering. A lot of people don't want to look at pain because there's a lot of associated fear, helplessness, frustration, and a lot of negative recourse in life, past regrets, present regrets, and future regrets. But I think holistic intervention possibly should focus on engagement. I like your word engagement. Focus on living instead of just dying. Now we have to work on different people have different strengths. Some people are more kinesthetic, some people are more visual, some people would be manifest themselves through music. So we develop different professions in order to elicit different strength and capacity of different individuals. But Australia is already very, very powerful because you have art therapists, music therapists, massage therapists in your palliative care teams. But it is always not enough specialists to go around. Have you heard of the conductor training in children for spastics?
Could you explain
from Europe? They're training for conductors. Which include elements of big muscle physiological training, occupational small muscles training, day-to-day work, teachers, social workers. They integrate all of these roles into a person called conductor. So the conductor trains these children through singing, so left leg up, right leg up, you know, in order for they sing, they eat, and activities in class. Even personal care workers will be trained in this holistic approach for the children to be coping with their day-to-day lives. So I'm thinking in palliative care and integrative care, we probably should be thinking of ourselves being just in case you are the only person in this team, and how we can empower ourselves to be able to see the strengths in each and every one of our clients whom we serve, so that we can facilitate them to use and mobilize their strength to find their life most meaningful and gratifying for the last days of life, no matter how long that is, because now with target therapy, with a lot of healing techniques, people do live much, much longer than expected. And metastasized patients live forever. You know, some patients live really, really long, enjoy really long years. So through my conversation with long exceptional survivors, some of you may know John Cardoza from Malaysia, who is a very active volunteer. And he said he'd done nothing except one thing. He sit and meditate. He was a Catholic, and he sit and meditate with one sentence: "God come inside of me." So he do that 1 hour every day. That's all that he did. So different people use different means. This can be really powerful. God come inside of me.
Could I ask you this? I'm thinking here now of emotional or spiritual suffering, and not simply pain management, if I could leave that as an area that I think people are very generally effective at. What's one thing that we haven't mentioned at the conference so far is that a lot of people are alone. There's a documentary at the moment showing on Qantas flights, if anyone's flying, you can find it, about the proportion of people in major cities around the world who are actually living alone. And there are now many cities where the majority of people are living alone. I've recently had a serious illness, and I saw many people receiving treatment alone. And I'm interested in this issue if one is completely alone and is emotionally suffering, the extra challenges for health professionals who are seeking to assist them when there isn't a family to engage with. I wonder if I could come to Dr Cassane on that.
Certainly, I think aloneness is a major challenge. To be single is a demographic that highlights, in fact, shorter survival likelihood. And being single not only means being unmarried, but it means separated, widowed, divorced. An important study 12 months back looked at 75,000 cancer patients across the 10 most common cancer groups and identified that patients who were single had substantially shorter survival than people who were married. Being single is as problematic as high cholesterol, smoking, and chemotherapy, and the gain that chemotherapy brings is really equivalent to what is lost when people are single. So to identify that single status is crucial. Many people are alienated from their families. Again, this is something that's not discussed a lot, but I'm sure you would come across it often, where people actually don't have contact, even if they have children. Could I come to this question of family dynamics, because it's another theme I've been asked to raise with you, that in this attempt to offer holistic care, what role does the family play, particularly if the family is not functional? And I know you've got 3 C's, and we all love 3 things, so can you tell us about them? The 3 C's. Well, one wants to recognise resilient families, of course, to find something that you like about each family that you work with. So important to family-centred care. But we've not been taught very well, I think, how to recognise the family who's at higher risk and who needs more support. And so the 3 C's, the letter C of relational life in family, are 3 questions that you can ask of family life. Ask about cohesion. How's the teamwork in your family? What's the cohesiveness like? Ask about communication. Do you talk openly and easily in your family? And ask about conflict. How do you deal with your differences? And if clinicians inquire about those 3 C's of relational life, cohesion, communication, and conflict, or conflict resolution, then you're able, I think, to discern the families who are resilient and who will do well from families who may be at risk and in need of some further support with a model of family-centred care.
And if someone is referred to you in that context as needing extra support, what sort of things can you do for families that are struggling?
Well, we're talking about meeting with the family more often and making the family meeting a model of care so that instead of individual sessions, you invite people to come with their carers, to come into the consultation room and meet with the family. And so the philosophy of support is more family-centred, and you're inviting the family to take up a mutual responsibility of care and support for each other as a way of working together to help with the care of the sick person, but the care of each other as they journey with the illness.
I know you do work on how to conduct family meetings, and I know there's brutality in the question I'm about to ask you, but can you give us 2 or 3 of what you see as the key principles to an effective family meeting when you're working with a family that is clearly in trouble?
Odette's lining me up to do a workshop on how to run a family meeting in the months ahead, and be very happy to do that, a whole day. To build skills, and skills are there in terms of the questions that we ask and the summaries that we offer to the family to affirm and to help the family to follow where we're going with the family meeting. So it's hard to summarise that, I think.
Know it is. It's a horrible thing to do, but can I give you treat it as an ad that they've got to decide whether to come to your workshop. What will you offer them in that day?
In the end, families want to know that a family meeting is going to be safe, and there are going to be agendas that they'll have addressed. So agenda setting is a key part of it. It's done as a mutually developed exercise at the commencement of the meeting. What are the family's needs? What are their unmet needs? And how are they getting on as a group? And if you in fact unpack that with them, how's your communication going as a family? How are you dealing with differences of opinion? If you unpack some of that, you'll identify issues or concerns that you can invite the family to continue to work with. So we were talking before about avoiding stigmatising jargon, and we tend never to say to a family, you've got your problems, haven't you? Because that offends people and puts them off. So subtle language includes a word like a concern, or is that an issue for you? As a family, are you telling me that it's hard to talk about death and dying? That seems to be something you avoid. That seems to be an issue. What's it been like over this last half hour, talking more openly about that possibility of death and dying? And so you free the family up, and then once you're making progress like that, it's a very affirming model of care, where you've got to congratulate the family for the things they're doing well and use that strengths-based orientation as a way of encouraging the family to go forward.
So you're sort of helping them to help each other. Yes. Jenny, your thoughts, because I gather that you often will see situations where families are in trouble. How do you approach it?
Oh, that's an interesting one. If we go back to the family meeting situation, I think it's an underutilised opportunity to really work with what Tenno called that patient-focused, family-centred care. And I really like that phrase, because what it's saying is the patient is really your core reason for being there, but that person lives within a context of a family, and they often can't do what they need to do without that family. Sometimes they're not allowed to do things, sometimes they do too much. But that we all live in this social construct. So it's really important for us in our assessment and in our discussions and any interventions that we negotiate with all of the people in the family. So I think it's absolutely crucial. And in terms of family meetings, it's not always done well. And I think it should be a core practice that we all do for families. And I say this both from the perspective of a clinician who's sat in family meetings and as a daughter who's been a participant in a family meeting, and seeing it from the other side of the fence was enormously eye-opening. And I think the theory that we include family and we negotiate is all wonderful and it's very lofty, but we don't always translate it very well in practice. And I think we need to support and educate each other, because my experience as a clinician is that often the team goes in with a set agenda in a way, and it's not a genuine negotiation. And my experience of it as a family member is that I was just completely overwhelmed, and I'm a health professional. I would say my health literacy is pretty damn fine, and yet I felt completely overwhelmed, overlooked. I felt raced into decisions and discussions. I can't tell you what was said in that meeting. I couldn't tell you. And it was a great eye-opener for me to reflect on the language that I use and to question myself about what my agenda is and try and put that aside and genuinely say, and I think you mentioned this, what's important to you? What do you need to know? What's your understanding of what's going on? And work, you know, it was said yesterday, work from where that person is at. Because if you don't show from the get-go that you're willing to listen, understand and work with the person as opposed to for them or against them, it makes everything so much harder than it needs to be. That's my feeling.
Professor Chan is desperate to speak.
I would like to share with you resources. Some of the movie that I show just now is actually on the internet. It's enable.hk. Enable is an empowerment network for adjustment to bereavement and loss and end of life. It has an English and Chinese version. So, and it has two components. One component is death preparation and end of life decisions and all that. And the other one is on bereavement, where there are sections besides those videos that you can click on with English versions that you can show your patients and families. There's also very beautiful affirmative cards that you can click and send to someone to send a goodwill, or steps to help prepare yourself or your clients on grief and bereavement, how to organize celebration of life and things like this. I wasn't able to show you some of the videos because of limited time. One of the video is a woman, 46 years of age, two young children, 42 years of age, two young children, and she organized a farewell party 3 days before she died. And it was during her birthday. So her card was birthday party, celebration of life party, and farewell party. So she chose her own slides, and there were integratives and say, I have no regrets in my life. And her husband and the two children say, we will miss you, but then we will work hard, and we'll, you know, things like this, which are beautiful. So all of those videos are online that you can access to, and it's in English. So the families, members would be able to look at some of those, although they may not like to come to a meeting or actually verbalize, especially the teenagers or the men who hate coming to counseling sessions. But internet is a really powerful means that you can try.
Thank you so much. We've only got 10 minutes left. I just have to meet one person, and then I'm coming to that gentleman and you two, and we're going to somehow make it all fit. Robin Reed, where are you? Are you here, Robin? Hurtle towards me, don't miss a moment. Robin is a shared care worker with people with motor neurone disease in the Southern Metro region and a palliative care consortium. When in a nutshell, what's the work you're doing with people with motor neurone disease?
My role is to provide support for health professionals and to provide information and education around the needs of motor neurone disease clients, and to educate people about the best practice around palliative care and to help people to get early entry into palliative care. I'd just like to make a comment about Jenni and rehabilitation. For people with motor neurone disease, it's such a hideous disease, and there's such a great loss of function progressively throughout. Early referral is very important because while people still have speech, it enables us to do a lot more work with them. It just gets a lot harder down the track. And they receive a thing called neuropalliative rehabilitation, which means that they are constantly doing catch-up with functionality, and they have a multidisciplinary team which works beautifully together to provide that constant adjustment with equipment and function and care. And of course, they live longer and they have a better quality of life because of that.
Tell me how you deal with the spiritual, mental side of suffering and pain and helping people with that.
I think that's about everybody's their own personal frame of reference for those sorts of things, and it really is just about listening and about allowing people to explore that dimension and to help them make meaning out of their world and the things that are happening to them.
Is there anything we've missed in this conversation when we've been talking about holistic care that's relevant to your people?
Well, to all people, I just think we need to really find out who the person is first of all and work with that. It's not about us, it's about them and their life and their choices and their values, and that's what we should always be focused on.
Look, thank you. Thank you very much for that brief moment. Guys, we've only got a short amount of time, and I'm going to come to as many of you as I can. Brevity will be much appreciated. Do you want to stand, sir, and introduce yourself?
Brevity might be difficult because I'm Irish. My name is John Coleman. I'm a volunteer Reiki practitioner in Fernley House Palliative Daycare Hospice in the Dandenong Ranges. I also advocate nationally for the integration of Reiki into mainstream healthcare with growing success. My question is to Dr. Chan. First of all, thank you for your enlightening and practical demonstrations. I particularly liked your statement, you don't have to believe in it for it to work. My question is, have you had opposition with the introduction of your Eastern philosophies and demonstrations, etc., from mainstream? And if so, how have you worked through that?
Thank you so much.
Because I'm teaching in the university, so I don't have clinical duty as such. So most of my work is on clinical trials. So people who are willing to come and they enroll into the clinical trial. So I don't have a lot of problems with that. And most of these techniques are safe. You know, they don't have a lot of, they definitely are not mainstream. But I would also like to tell you another very simple technique is that besides the basic 101, we always talk about gut feelings. So the abdomen area is the emotional cortex as well, because that's where our gut feelings are. So you can also rub your hands and put it there while you go to bed, or teach your patients to be doing that. That's very soothing, and they sleep better. For those patients who always have fear, anxiety, so it would be really easy for them to rub their hands and pound on their chest. Old grandma do that to us when we were children, when we were scared. They pound on our chest. Do you do that in your culture? Yeah. And these a whole set of hormones and glands and acupuncture points that give you the courage and confidence. It's so easy. No, a lot of anxiety patients told me that this single technique is very, very useful.
Thank you very much. Your question or comment?
Judith Morales here. Look, when you were talking, David, about family resilience and the 3 C's, you know, cohesion, communication and conflict, one of the things that just kind of flashed into my head was the word culture or cultural diversity. And I know that cultural diversity has been sort of on the periphery. But of course, you know, more than 25% of Australians are actually from either born overseas or have a parent who was born overseas. So it's a huge issue. And for families that have come here as migrant and refugees, I mean, the resilience of the family is incredibly challenging. I come from a migrant family. It's just my parents, myself, and my 2 brothers and sisters. And so when we're talking about resilience, the issue of, you know, who's the network, how do we build capacity, how do we cope, it's kind of a really important subtext that should actually become a major theme, shouldn't it, I think?
I agree with all that you say, so profound. To be curious about the culture is essential. Tell me more, as Bob Arnold would say. Let's really understand that. And to affirm the courage that's part of all migrants' stories. The courage of that journey is profound. And so there's a lot of resilience to see there and to affirm, as you so rightly say.
I'm going to take 5 minutes of your extended lunch, if that's okay, just so we can get a couple more questions and then we have some awards.
Thanks, Julie. Peter King, I'm a twice carer for achieving a good death in my home of my wife and my mother. The question I've got for the panel, please, is I was especially interested in your comments about the difficulty that you have, or the opportunities as well, for creating family dialogue, beginning with a family meeting. In my experience, the specialist palliative care nurses would come to our home and have a family meeting every time they were here, whether it was called a family meeting or not. I don't think it ever was, but the benefit of that was a huge amount of very close communication. I'm just wondering if the panel members identified problems with establishing meaningful communication in a family meeting. Are those would those comments be likely modified if it was on the turf of the family? So that's my question. And also, one of the audience members would like Dr Chan, please, to read out slowly the URL for her the website, please.
Thank you. Let's just do the URL first, if you could just give a micro.
This is enable, E-N-A-B-L-E, enable.hk. So
.hk. Enable.hk, excuse me.
Yeah, enable.hk. So if you cannot get it online, Google it, and then this is the Empowerment Network for Adjustment to Bereavement and Loss in End-of-Life program. That's both in Chinese and English. Another one is Hospice Home. I think it's also .hk. Hospice Home in one word, HOSPICEHOME. But that one is only in Chinese, but also had an apps mobile phone option, which also contained in the library section 10 video on the actual how to deal with the different symptoms of constipation and indigestion and things like that.
I'm going to be running out of time, so I just have to warn you about that. I'm sorry. A quick reaction. Why don't you have your family meetings on the family's turf? It'd go better.
Wonderful, Peter. Thank you for that account, and wholeheartedly agree. Nothing better than a family meeting in the home, and we need to empower clinicians to feel skilled to conduct them, facilitate them, make them happen.
Jenny, leave the hospital. What would you do? You wouldn't be able to function.
I leave the hospital all the time and I love it. I mean, it's a core role of OT is to go and do home assessment. We visit people in the home. Frankly, it's my favourite part of my work because you're seeing the individual in their context instead of plucking them out of their house, plonking them in your weird place with your weird language and expecting them still to function. So I'm all for it. And I probably should qualify my earlier statement by saying about family meetings, when you have skilled clinicians, they are fabulous. I've seen really, really good ones and I've seen some absolute shockers. And I think it goes back to the thing that seems to be core through all of this, which is about skill, training and a desire to improve care. But I agree with you.
I'm going to take one more because the woman's face is intense. You're the one.
Really, I'm only just adding to what you just raised. I am now a volunteer with Banksia Palliative Care, but in my working life, I cannot tell you how many family therapy type meetings I have sat in on. Very early in the piece, when I was far too young and naive to dare to speak up in front of all these important people, I thought to myself, there is something wrong here, because they almost always took place in a room with somebody outside a two-way mirror observing, being filmed for training purposes and so on and so forth. And I think that we need to do an enormous amount to casualise. And that's very...
What do you mean casualise?
Well, I think you need to have a space to work in with families which is friendly to the families, and their own place obviously is ideal. I have seen one or two where they have a sunny, pleasant room with toys for the very small children, if you happen to have that in your family, and the kids are allowed to make a noise and run around. but it actually comes into the family level. The other thing is, I would plead with everybody to please drop the middle class jargon. You have to be able to speak, and if you think about effective communicators that you know, they are able to interact with people from all kinds of different walks of life. They don't change their personality or who they are, but they're able to be with the person in a non-formal way, which I think is far more powerful than most of the stuff I sat in on.
Okay, thank you. I'm not going to ask for comment. I think that was a powerful and wonderful ending to our session. But I would ask you to thank Professor Chan, Dr Kissane and Jenni Bourke.